Hi, Daryl Baskin here. I'm a retina specialist. I'm currently in France right now studying language. However, I wanted to finish this lecture that's geared towards residents. This is part three, the final part of a series on central serous chorioretinopathy. This part is directed towards management of CSR, which is fairly complex. I have no financial conflicts of interest, and off-label uses of medications will be discussed. CSR, we've already talked about history, pathophys, differential diagnosis, history, exam, diagnostics, and now we're going to kind of go into the meat and potatoes of what is necessary to discuss with patients with central serous. So first you need to know the natural history, and that'll kind of explain why the decision to treat is so complex. 80 to 90% of eyes are going to improve on their own within about 4 months. That's an old statistic. It may not be very accurate now with different risk factors that have increased in the population, but in general, that is probably still true, and it is certainly what I counsel my patients. Visual acuity may take even longer. Subretinal fluid goes away. Visual acuity always lags the OCT is what I tell my patients and residents, and that's certainly the case here. The moment the fluid goes away, then you still have those elongated outer segments of the photoreceptors that take a while to resorb, line up, or whatever it is that they need to do in order for visual function to work normally. So there may be permanent changes in vision, color vision, contrast sensitivity in particular. You may be left with some blind spots as well. So that's not perfect, and that's why we want to intervene before a lot of those happen. And then about half of folks will have a recurrence at some point in their life. And I just want to remind everybody, if you stop steroids, 88 to 100% of people will get improvement just by that intervention alone. So again, risk factor modification, treat the underlying causes if you can. If sleep apnea is being considered, certainly get a sleep study and then begin CPAP. Although, again, I've mentioned this before, there's no evidence to suggest that in and of itself will treat the subretinal fluid directly. There's unknown benefit of treating Helicobacter pylori. This is from the first lecture a little bit. Stress management is something I counsel people to get, but that's not particularly easy, and we also don't know if that actually makes a difference. So before I left the United States, I took this picture at Target, and many of you may have seen that Flonase or fluticasone is now available over the counter. So it may be that we see a commensurate rise in central serous cases. So classically, the decision to treat, this is from the BCSC course, is based on these sort of ideas of a serous detachment that persists for a while, 3 to 6 months. If the disease recurs in eyes that already have visual problems, scotomata or metamorphopsia, a permanent visual deficit from a prior episode is in the fellow eye. If you have chronic signs that begin to develop, which I would never wait for that to happen, but RPE changes, intraretinal fluid accumulation, and this is something I saw a lot in the Air Force, and that was occupational or other needs require treatment. So I had a lot of fighter pilots that would not tolerate, just like I wouldn't, scotomata or visual problems from CSR. So we would have a lower threshold to treat. And so I'm just going to kind of bring out this little graph. You could kind of break down CSR into no prior episodes and whether it's an acute first episode or a chronic first episode, or if they've had previous episodes and now they're having a new one that's acute or chronic. We kind of have the spectrum of observation versus treatment. And I would say in the old days, we waited a long time to treat, but nowadays that threshold has been lowered, or in this case is moving to the left, because we have more treatments, and some of them are more promising than the old ones were. So treatment options in the old days, there was psychotherapy. This is not necessarily going in chronological order. There's been lots of, in the old days, again, alpha or beta adrenergic blocking agents, which we don't use anymore. Acetazolamide not used at all. These corticosteroid antagonists I'll talk about at the end of the lecture, and then aspirins, that was kind of a one and done sort of thing. Some people still talk about anti-VEGF. I don't think there's a lot of good evidence for that, and I'll talk about that briefly. And then lasers, retinal thermal photocoagulation was sort of the gold standard for a very long time. TTT is not used anymore. And then nowadays you see papers mostly about PDT, photodynamic therapy, or about micropulse. So the orthodoxy is this: you get steroids or some other precipitating event or predisposition. Something leads to choroidal vascular hyperpermeability and choroidal thickening. That leads to problems in the RPE, retinal pigment epithelium, and then you get subretinal fluid, and then that more or less is the simple way to think of central serous chorioretinopathy. Some of the treatments are directed at stopping the steroids. Obviously, helps a lot of folks. We talked about that a lot. Thermal laser kind of welds those RPE defects shut. Micropulse would probably fit into this category. I don't know as much about that. I've only tried it a couple of times. And then you get PDT, verteporfin photodynamic therapy, and that really kind of addresses probably the most underlying cause outside of stopping the steroids. Again, a lot of people aren't taking steroids, so then that doesn't help them. I've just put a couple of little charts up here. Dr. Watsky in Iowa, 1974, published a study on median time to resolution of subretinal fluid from folks that got thermal lasers, about 5 weeks. And then for the folks that did not, that were observed, it was 23 weeks. So there's no difference, and he also said there's no difference in final vision despite the shorter disease duration, nor is there evidence that treatment, the thermal laser, altered the recurrence rate. So this is like 41 years ago. And I don't think anybody's had much to add to that in terms of modifying the chance of having additional recurrences or the visual acuity. So again, that's why we've had the basic clinical science course has like all those treatment criteria 5 that I mentioned earlier, because thermal laser, you got rid of the subretinal fluid, but at the same time didn't always result in better vision. This other study is really looking at micropulse, but it was not a very well designed study. For one, it wasn't randomized. Number two, they don't even have a graph for, or at least I didn't have access to it, what percentage had complete resolution of subretinal fluid. They just have, their benchmark was improvement in leakage at 16 weeks. Improvement in leakage is kind of a little bit more of a fuzzier, less well-defined criterion. I'm sure they defined it well, but at any rate, I just didn't feel like you could really compare this to other things. They certainly, if you look at the 60% improvement in leakage at 16 weeks with micropulse versus 37.5% in the control, of course the micropulse looks better, but it doesn't look as good as PDT. And if you look at their study, the PDT group had the best contrast visual acuity at the end and the best corrected visual acuity. Had 62 patients, so it was a nice large study. But again, if you think about it, in Watsky's study, the observation group at 23 weeks, 50% of them, on average, had complete resolution of their subretinal fluid. So this Kretz study out of Germany at 16 weeks, 37.5. Well, if you wait a little bit longer, that would have been 50%. So to me, it just seems to me that the micropulse isn't a whole lot better. But again, we're not even looking at subretinal fluid resolution. So enough said about that. Now, photodynamic therapy, I think, arguably is the gold standard right now, although it might be eclipsed soon by some other modalities. I'm not going to spend as much time talking about it as I would like, but just remember that, in my opinion, right now, it seems like it's the most reliable treatment to go with. ICG is necessary to decide the dosage the laser spot size for verteporfin-based photodynamic therapy. I'll only say PDT from now on. ICG is very helpful in the diagnosis. I don't think it's necessary to make the diagnosis of CSR, but if I have a patient that I'm considering treating with CSR, then I'm always going to get an ICG. Inoue et al., and references will be at the end, characterized patients with CSC into 3 groups based on their ICG findings: intense hyperfluorescence, intermediate hyperfluorescence, and no hyperfluorescence. In the 2 groups with the intense or the intermediate, after their PDT, all their subretinal fluid eventually resolved within 6 months. But in the groups with no hyperfluorescence, their subretinal fluid never resolved during the study period. My thought is that the folks that had no hyperfluorescence had kind of already developed this sick RPE type syndrome where their RPE can no longer pump out the fluid, and even though the ICG being hypofluorescent suggested that the choroidal vasculature was not all that leaky, there was still this derangement of the normal state of the retina, RPE, and the choroid, such that even though PDT reduced some of the choroidal permeability or thickness, if you will, it still didn't make a change because it was sort of, in the way I think of it, just too late for the RPE to come back to life and actually make a difference. So what I think about that is if you catch somebody that's got central serous chorioretinopathy, they're going to have a better prognosis the fresher you catch them and treat them. Again, that kind of goes in contrast with waiting 3 to 6 months. So you have to find the right balance, and that's oftentimes dependent on individual patients. The other concern with PDT, well, there's a few concerns with PDT, is choroidal ischemia. As to the best of my knowledge, that's only been reported in standard PDT full dose, full fluence, which most people do not advocate doing in central serous. PDT was originally FDA approved for wet macular degeneration. And so with folks with CSC, most people either do a half dose of the medication or a half fluence, or basically half of the laser power. Choroidal ischemia is something that I am concerned about. I always counsel patients about. I think it's 4% in wet AMD patients, but again, they have a thin choroid going into the procedure, whereas CSC patients always have a thick choroid. CNV secondarily is a concern. Again, that's probably more likely with standard PDT. And then back pain in 10% is what I quote people, although in my experience it's been less than 10%. And the back pain resolves after the infusion ends. And then, of course, photosensitivity for 72 hours. A couple of studies here. The first one's with Chan, 63 patients. This is a randomized controlled trial, double-masked, with acute central serous chorioretinopathy. That had to be 2,200 or better and less than 3 months of subretinal fluid. They compared placebo versus half-dose PDT. And you could tell that within 12 months, 95% of the folks that got half-dose PDT had complete resolution of their subretinal fluid versus only 58% in the placebo. Ribaldi looked at 42 patients, prospective, non-randomized, and they had chronic CSR. He looked at half-fluence PDT versus standard, and he actually had better results with the half-fluence PDT. And the standard PDT, he had several eyes, actually a little over a third, develop severe choriocapillaris non-perfusion. One developed CNV. So there's another study by Zhao that looked at various doses of verteporfin in the treatment of acute CSC, and he noted that a 30% dose may be optimal, whereas most of the half-dose folks, it's 50%, obviously. So this is kind of our orthodoxy, or what we believe about CSR. Some of the new thoughts are, I'm calling unorthodox, primarily because they haven't been fully proven yet. There's not a lot of data. So anti-VEGF, I've had several other retina specialists tell me that they've used anti-VEGF with some success. I personally don't advocate the use of anti-VEGF injections for CSR. We do know that VEGF's first name was vascular permeability factor, named by Dr. Sanger in 1983, because of its primary property in tumors, which is to cause vascular permeability. So there may be some small effect that putting an anti-VEGF in the some small effect of anti-VEGF, but I don't think it gets to the underlying pathophysiology. So anyway, intuitively it would make some sense that these may work, right? But then one study showed that aqueous and plasma levels of VEGF are not significantly increased compared with healthy control, so CSR patients don't have a surplus of VEGF to begin with. And there have been no large prospective randomized controlled trials to date. And in 2013, a meta-analysis showed no positive effect of intravitreal bevacizumab over observation. So in my mind's eye, that settles the question for me. So here's another unorthodox view. I kind of tried to represent it. I tried to represent it graphically, not because I believe in, although it took a long time to put this part together, but just to conceptually visualize it. The red icons are glucocorticoids. The yellow ones, as labeled, are mineralocorticoids. The green receptor is the glucocorticoid receptor, and the blue one is the mineralocorticoid receptor. So that's how they fit. When you have a surplus of steroids, again, this is sort of the steroid hypothesis, you have all these glucocorticoids floating around, and they can actually displace the mineralocorticoids and stimulate the MR, the mineralocorticoid receptor. So when they have this kind of long-standing occupation of the MRs and the GRs, but primarily the MRs, you get this stimulation of these calcium-activated potassium channels that then create choroidal vascular hyperpermeability and choroidal thickening. So that leads to this vasorelaxation. This calcium-activated potassium channel is not expressed in retinal vessels, but it is found in the choroidal vasculature. And then there's another thing that's expressed normally in the choroid, which is this 11-beta hydroxysteroid dehydrogenase type 2. It's a mouthful. It's HSD2, which goes in and transforms the glucocorticoids into metabolites that have a weaker affinity for the MR. So HSD2 keeps the glucocorticoids from overstimulating or overactivating the MR receptors. My theory is that in patients with central serous, they may have too little HSD2 activity. It may also be that in patients that are on Durezol or get IVK or Ozurdex, etc., and don't develop CSR, that the reason that they don't get CSR is that these local steroids somehow upregulate HSD2 and keep the MR from being overactivated with all of its downstream effects. But who knows? So rifampin has some anti-glucocorticoid receptor properties. It does have some side effects of hepatotoxicity. Again, there haven't been any prospective randomized controlled trials with it. Eplerenone and spironolactone are both mineralocorticoid receptor antagonists. Spironolactone is a lot more sticks to the MR binding affinity to the mineralocorticoid receptor than eplerenone does, but it's also got a lot of anti-androgen side effects. So I did a PubMed search, and there were about 9 articles on eplerenone, 13 for spironolactone, and there's some crossover between those two. Eplerenone was used 25 milligrams per day for a week, followed by 50 milligrams per day for 3 months. And again, you have to watch out for hyperkalemia with eplerenone. And here's just a couple of quick studies with eplerenone on the left. Bosquet in France looked at subretinal fluid resolution at 3 months, and 69% had resolved by that time on eplerenone. Schulman looked at rifampin over the same time period, and about 42% had resolution of subretinal fluid. So again, the data is still pretty early. Conceptually, I like how this might be a little bit more fine-tuned than PDT is, but you are talking about the potential for having a long-term medication, and then you have compliance issues, etc. There's no perfect treatment right now. You also have to remember that for people that get treatment, PDT does lower the recurrence rates, but there still is a chance for recurrence. CNV can develop even if there is no treatment used, but particularly in treatments that involve thermal laser or full dose, full fluence PDT. And then you also have to consider focal choroidal excavation associations and CNV as well. So bottom line for me is if you're taking steroids and you have CSR, I would strongly consider stopping the steroids under the guidance of a physician. Never stop the steroids cold turkey. See a retina specialist. The decision to treat is still complex because sometimes the disease improves on its own spontaneously, and also because none of the treatments are without consequence or adverse effect. If treatment is necessary, I'd still consider half-dose PDT or possibly a mineralocorticoid receptor antagonist such as eplerenone. But again, all patients with CSR should see a retina specialist for the rest of their lives, and they need to be monitoring an Amsler grid at least once a week. I would do it once a day with one eye at a time. Again, sorry about some of the choppiness of this lecture. I just wanted to finish it, and I know that since I'm not seeing patients right now, I won't be for the next few months. if I don't get it done now, I won't get a chance to get it done later. So anyway, if you're still listening or watching, thank you for your patience. And here's my reference slides. And if you want any further reading on some of the molecular hypotheses, I recommend the references from Zhao. I think they're on this slide. That second one that involves rats was really interesting. So anyway, thank you for your time, and that's it. I'm signing off.